Dr. Jauri and Dr. Bupath?
I'm just entering the building just now, so I'll check.
You'll check, okay. Maybe they'll come to life on your way.
So Dr. Bupath and myself, Dr. Jauri, we are here, and we are ready to start. Well, there's no one in the audience yet, but I can see that online we do have quite some people.
Okay, wonderful. Let's wait a few minutes. Dr. Jauri, are you the one going first?
Yes, I'm the one going first.
Dr. Jauri?
Yes, I'm going first.
Yeah.
Okay, yeah, let's just give a few minutes.
All right.
Okay, sure. I'll introduce and then you can come on.
Sure.
I think let's start. It's 7:33. Good morning, colleagues. Today's journal club is from Mahatma Gandhi. The seniors are engaged in another process at work, so they couldn't be with the registrars. Dr. Jauri and Dr. Bupath have prepared
Recording
articles.
in progress.
The first article is on endometrial sampling. When you get a lady with increased endometrial thickness and the sample comes back unrepresentative or negative. Now, Dr. Jauri will take us through that. Over to you, Dr. Jauri.
Yes, morning everyone. Thank you, Prof. So, Mahatma Gandhi Memorial Hospital will be presenting the journal club today. And we will start off with the gynae article. So it is a research article only published this month in the American Journal of Obstetrics and Gynecology. It was a study that was carried out in Denmark, looking at the risk of endometrial cancer.
Sorry.
Yes. Yeah, so looking at the risk of endometrial cancer after insufficient endometrial biopsy. It was a retrospective cohort study. So this journal club was supervised by Dr. Ismail and Dr. Peter. So starting off, a postmenopausal bleeding is vaginal bleeding after a period of at least 12 months of amenorrhea and is most common shortly after menopause. It can of course be a sign of endometrial cancer. Therefore, thorough examination to exclude malignancy is required. Danish studies showed that approximately 5% of individuals with postmenopausal bleeding are diagnosed with endometrial cancer, and this is usually done through an endometrial biopsy. An endometrial biopsy is sufficient when the pathologist judges there is enough tissue to make the diagnosis. However, strict criteria are missing. The risk of insufficient endometrial biopsies is associated with nulliparity, advanced age, a thin endometrium, intrauterine fibroids that can distort the uterine cavity. Insufficient endometrial biopsies can be due to difficulties with getting access to the intrauterine cavity, could be due to stenosis, and a thin endometrium whereby the sampling device fails to collect appropriate tissue for analysis. So the Danish Society of Obstetrics and Gynecology recommends endometrial biopsy to exclude endometrial cancer in cases of postmenopausal bleeding and when the endometrial thickness is more than 5 millimeters or indistinct. A well-defined and less than 5 millimeter endometrium using transvaginal ultrasound. Here, the society does not recommend a biopsy to be taken and advises that the patient comes back in case of rebleeding. Endometrial biopsies are quite often insufficient, and a new hysteroscopic guided endometrial biopsy is recommended. DNC is rarely used for diagnostic purposes in Denmark due to the need for general anesthesia. Some biopsies yield insufficient tissue for diagnosis, and hereby a repeat biopsy is, of course, recommended. However, some clinicians do not repeat the biopsy and interpret it as endometrial atrophy. An atrophic endometrium is, of course, non-proliferative and hence minimal risk of cancer. Other risk factors should also be considered, like endometrial thickness on the ultrasound, body weight, and ethnicity of patients. So the aim of this study is to assess risk of endometrial cancer after an insufficient biopsy. There's limited data on outcomes after insufficient biopsy, and this applies to both premenopausal and postmenopausal bleeding women. So the hypothesis here is that individuals with an insufficient index biopsy have a higher risk of endometrial cancer than those with a normal biopsy. Coming up to the methodology, so this was a nationwide retrospective cohort study in Denmark, whereby they retrieved endometrial samples from the Danish Pathology Register, which is a very comprehensive register countrywide. Danish individuals who have had endometrial biopsies performed between 1st of January 2013 to 31st of December 2017 were included in the study. An index biopsy was a first biopsy from the endometrium, which was not a follow-up control of a previous biopsy. A follow-up biopsy was a biopsy that was preceded by another endometrial biopsy within 12 months. So here on this flowchart, we'll look at the exclusion criteria. So on the left side is the index sample, on the right side the follow-up sample. So there was initially around 158,000 samples that were included, and of them 45,000 were excluded as being non-endometrial biopsies, biopsies of hysterectomy or straight out cancer. A further 24,000 were excluded as they were performed more than 1 year before the start date of the study. And finally, around 8,000 samples were excluded as they were biopsies taken for the same patient on the same day, and only the biopsy with the worst histology was included in the study. So finally, there was 80,761 individuals in the index biopsy group. Around 58 had normal biopsies. Around 13,000 had insufficient biopsies. Around 4,000 had hyperplasia, and around 4,000 had cancer. Looking now at the follow-up samples, so initially there was around 55,000 samples that were selected. Around 12,000 were excluded on the first round due to being non-endometrial biopsies and straight-out cancer, and a further 15,000 were excluded as they were samples taken from the same patients, and only those with the worst histology were included. So there was finally 27,673 individuals that were included, of which 18,000 were normal, around 2,700 were insufficient, around 2,000 had hyperplasia, and 3,900 had cancer. So the individuals were divided into 4 groups according to their index histology, whether it was normal, insufficient, hyperplasia, or cancer. Hyperplasia with atypia was categorized as cancer. There was a 4-year follow-up period as the authors assumed that any index cancers that were overlooked due to insufficient sampling would reveal themselves in this period. Follow-up endometrial samples were obtained from the same pathology register. The registered data included age at test, date of the examination, histological finding, and the Danish region where the sample was examined. There was unfortunately no access with regards to endometrial thickness and other clinical measures such as height, weight, parity, hypertension, diabetes, PCOS, hereditary non-polyposis colorectal cancer, tamoxifen, or hormone replacement therapy. There was limited access to the method of collection, so the authors did not know whether it was a blind endometrial biopsy or a mini hysteroscopy guided one. The average age at menopause is 51 years worldwide. The authors did not have access to whether the patients were postmenopausal or not, and they used 50 years as a pragmatic cutoff. And then they stratified the results according to age, less or more than 50. So we'll start off with this first table, which shows us the age-wise distribution of endometrial biopsies. So there was a total of 80,761 biopsies that were included. Of them, around 58,729 were normal, around 13,000 were insufficient, around 4,000 had hyperplasia, and around 4,000 had cancer. So now when we look at it in an age-wise distribution, women less than 30 years of age rarely had any hyperplasia or cancer at 1.5 and 0.1% respectively. Those between the age of 30 to 39 also had low malignant potential at 5.9 and 1.2%. Perimenopausal group, so those between the age of 40 to 49, showed a rising trend in hyperplasia and cancer at 31.2% and 4.8% respectively. As we move up the older postmenopausal women group, so above 50, we can see that we have the highest cancer prevalence peaking at the age of 60 to 69 at 30.9%, and hyperplasia peaking between the age of 50 to 59 at 38.5%. Therefore, the proportion of normal biopsies decrease with age, and the incidence of cancer increases sharply after 50 years, peaking at the age of 60 to 79. Most importantly to us in this study is the group who had insufficient biopsies. So this 13,964, which is around 17% of the group, we can see here that the number of insufficient biopsies increase with age, peaking at the age of 50 to 59, the same age period where hyperplasia and cancer are the highest. So now we'll move to this very colorful diagram, which is a Sankey diagram. So this Sankey diagram is a flow diagram that shows us how quantities move from one point to another. The width of each part is proportional to the quantity it represents. So this one tracks 6,130 women who had the index insufficient biopsy and visually illustrates us what happens to those patients over the follow-up samplings. So starting off on the left side, the light blue part, you can see that all the 6,130 insufficient index biopsies, 4,494 had a first sample that turned out to be normal. Around 1,000 had again an insufficient sample. 327 had hyperplasia, and 288 had cancer. So this sums up to around 10% of the samples turned out to be hyperplasia and cancer following an index insufficient biopsy. So on the right side of the Sankey diagram is those who had the second follow-up, Most important for us is those who had the normal and insufficient biopsies. So we can see that among those who had the normal biopsies, the largest amount, 4,600, did not have any repeat, obviously because it was normal. But there was a portion who did have a second repeat, which turned out to be normal, if we follow the green line. And then the blue line here shows us that there was a portion who again had an insufficient sample. However, most importantly is this portion who had a hyperplasia and another small portion who turned out to have cancer this time. Coming up to those with the insufficient sample, unfortunately, the majority of them did not have any second sample, most probably lost to follow-up, or if they were risk stratified as being low risk, maybe they did not have any repeat. But there was a significant portion who had a second normal sample, small portion who had an insufficient sample, and then very important is some patients did have hyperplasia and cancer. We'll now move to this table. So this table shows us how those with different index biopsies progress over time. It's somehow a tabulated form of the Sankey diagram. So of concern to us is those who had a normal biopsy initially and those who had an insufficient biopsy initially. We can note that those who had a normal biopsy had a 2.1% chance of progressing to hyperplasia and a 0.7% chance to progress to cancer over the 4-year follow-up period. Those with an insufficient biopsy had a 2.9% chance of progressing to hyperplasia and a 2.6% chance to progress to cancer, again over the same period. Also good to note that those with hyperplasia had a 5.3% chance of progressing to cancer over the same 4-year period. This is what we call a Kaplan-Meier curve, and it is a statistical graph which is used to show time to an event, and the event is most commonly a bad outcome. Here, the failure probability is shown on the y-axis, and time is shown on the x-axis. And the women were divided into 3 groups: those with hyperplasia, insufficient biopsies, and normal biopsies. So the failure probability here, represented on the y-axis, is the chance of developing cancer over time. Each curve has a shaded area, which represents the confidence interval. So now looking at the 3 different curves, the first blue one is those with hyperplasia, and we can see here that they had the highest failure probability. That is, they had the highest chance of developing cancer over time, which reached as high as 5%. Comparing now the second, the red and the green curves. So the red curve is those with insufficient samples, and the green one is those with the normal samples. We can note that there is a considerably high probability of those with insufficient sample biopsies of developing cancer, which is around 2%, compared to those who had a normal biopsy, which is only around less than 1%. Therefore, hyperplasia at index biopsy had the highest chance of progressing to cancer over time. And insufficient biopsy had a significantly elevated risk compared to women with normal biopsy, suggesting that insufficient samples still carry underlying pathology. The difference between the curves is statistically significant with a very low p-value, meaning that the observed differences are unlikely due to chance. So what are the clinical implications? The decision to repeat the procedure or not is a clinical dilemma. There's significantly higher incidence of endometrial cancer in individuals with insufficient biopsies at 2.6% compared to individuals with normal index biopsies at 0.7%. So when adjusting for age, which is a significant a confounding factor, the hazard ratio was 1.6. So the hazard ratio, it compares the rate at which an event happens in one group to the rate at which it happens in another group. And we can see here that these women had a 16% increased risk of cancer, which is very relevant in our clinical management. What do the international guidelines say about it? So the ECOG advises to use transvaginal ultrasound as a first line for measurement of endometrial thickness. And they do not recommend any biopsy if the endometrium is thin and the bleeding results. However, according to Danish guidelines, if the endometrial biopsy would have been less than 5 millimeter, no biopsy should even have been taken in the first place. The RCOG advises that hyperplasia without atypia had a 5% progression chance to cancer over a 20-year period, and therefore recommend a 6-monthly follow-up and to discharge the patients if 2 negative biopsies are obtained. However, they do recommend a yearly follow-up if risk factors are present. A hyperplasia with atypia, so for that, a hysterectomy is advised. And if the patient desires to preserve the uterus, they can be put on progestogens. Unfortunately, the studies do not focus on insufficient samples, but they do recommend a hysteroscopy guided one if ever insufficient samples are obtained. So in the South African context, there is no clear guidelines with regards to the management of insufficient biopsies. We do use the 5 millimeters cutoff as a thickening of the endometrium. And very often we repeat the biopsies either by a repeat blind endometrial curetting or in theater. Occasionally, the insufficient biopsies are interpreted as endometrial atrophy. Transvaginal ultrasound is a readily available tool for us and should be used more extensively for endometrial thickness measurement to guide us in our clinical management. Patients should be risk stratified and followed accordingly, and we should consider looking at the risk factors of the patients such as age, more than 50, obesity, PCOS, hypertension, diabetes, estrogen exposure, nulliparity, medication use as tamoxifen, and hormone replacement therapy. Hysteroscopy guided biopsies is a service available to us in some centers, and patients with high index of suspicion of cancer or significant risk factors should be referred in case of repeated insufficient samples. So the strength of the study, it was a large sample size and the largest study to date. We had a comprehensive follow-up of patients thanks to the Danish Pathology Register. Quite a few limitations though. So insufficient biopsies is only subjective. There was no data with regards to BMI, bleeding pattern, endometrial thickness, comorbidities, or medications. Menopausal women were defined as more than 50 years of age rather than by clinical definition. The authors were unable to distinguish between blind versus hysteroscopic guided biopsy. And it was assumed that endometrial cancer would cause symptoms within 4 years, but not all cases could have been confirmed. So to conclude, individuals with an insufficient index biopsy had a higher risk of being diagnosed with endometrial cancer over a 4-year follow-up period compared to those with a normal index biopsy. The association was attenuated after adjusting for age. However, it still carried a significant 16% risk of cancer. This highlights the importance of appropriate follow-up for individuals with insufficient biopsies, particularly among the older age group. Future studies should focus on risk factors and defining pathological criteria for insufficient endometrial biopsies. Thank you.
Any questions here in the room or comments? Online, any questions or comments? It's clear, straightforward that obviously open our minds to say let's not just discharge or dismiss patients with insufficient biopsy. Let's not assume that it's definitely atrial. It must be atrophy because they still understand it's atrophy, not just because we didn't get a specimen to use them college in that atrophy. It must be the specimen that says atrophy. If you had an indication for endometrial biopsy, because the indication obviously would have been that the endometrium was thick. And so if you went and did a biopsy and it says specimen insufficient, then we should obviously not regard it as a default as atrophy. I think that's what the main issue is here. Because if the patient is a hyperplasia, we know what to do. If the patient is a C endometrium, we know what to do. If the patient is a normal endometrium, we know what to do. But where we don't know what to do is the patient with insufficient specimen. Any comments or any other was clear, presented very well, that were also very clearly explained to us. If there's
Dr.
no,
Mason?
yes, go ahead.
Yeah, thank you. I'm not sure if Bhavna is still around. Yeah, but I just wanted to say it's a good article in terms of how they defined their participants and the large sample size, which was to their advantage. However, it suffered the usual retrospective nature of the study. But for me, significantly, is the fact that this is a Scandinavian, well-developed country where they still cannot even define whether the patient was menopausal or not. They had no information about endometrial thickness and a lot of data that I suspect that any histology form should contain. It just reminds me that we are all in the same boat because it's the same story with our own patients. You find that somebody takes a sample. They couldn't even tell whether this was a hysteroscopic sample or just a PPL. And just to remind ourselves that when there is a form given to us, we need to complete it to the best of our ability with the information that's available. I want to believe that the information was available. Clinicians seem to be the same everywhere. They are not completing the necessary information, sometimes making it difficult for the pathologist and the cytologist to interpret the data we give them, even for the index patient, not for the study. So yeah, just to reiterate that the information that has been put on forms, let's try and complete it as comprehensively as we can. Thanks.
I think the other aspect that one saw is that there were also younger age groups that were sampled, which means there is an indication for sampling. I think we discussed it last week when we had the grand round to say obviously the younger patients, if they are not responding to conventional treatment, we should sample the endometrium. I think that message also, although it was not part of the study, it obviously says to you, why was that patient sampled? There must have been an indication why the younger patients were actually sampled. And one of the main ones that one can come to mind is that they were not responding to conventional medical treatment. And that's why the sampling was done. So let's not neglect that part as well. As I say, not part of the article, but it just reminds us that there is obviously indications for sampling patients who are not perimenopausal or postmenopausal in terms of that. If no other comments or questions, let's move on to the second article. Thank you very much, Dr. Tauli. We hand over to Dr. Bupat, who is putting up the slides.
We present the second article on obstetrics. And my article today will be a relationship between the prior pregnancy loss and the subsequent adverse pregnancy outcome in women. It is a recent article that was published in October 2025, and my supervisor is Dr. Ismail and Dr. Hira. With a history of pregnancy loss, who attended the Department of Reproductive Medicine at the Second Hospital of Lanzo University, and to see if there is any risk of adverse pregnancy outcome. Adverse pregnancy outcome refers to the pathological pregnancy and pregnancy complication that deviates from normal live birth. It includes various conditions such as spontaneous abortion, stillbirth, ectopic pregnancy, preterm birth, low birth weight, macrosomia, and birth defects. Pregnancy complication includes gestational diabetes, gestational hypertension, intrahepatic cholestasis, and anemia. The aim and objective of the study was to determine whether the number of previous pregnancy losses increased the risk of adverse pregnancy outcome in the subsequent pregnancies. And the second, the age of the first pregnancy influenced the risk of adverse pregnancy outcome. Study design, it was a retrospective cohort with a nested case control approach between September 2019 to February 2022. It was done in the Department of Reproductive Medicine, Lanzhou University, involving 1,074 women. And it was divided into two, the case and the control. The case, there was 358 women with an adverse pregnancy outcome, and the control with 716 women with normal outcomes, with a ratio 1:2. And the analysis done was a conditional logistic regression and a restricted cubic splint for nonlinear relationship. The inclusion criteria, history of at least one previous pregnancy loss, attended the Department of Reproductive Medicine at the second hospital at Lanzhou University, had a complete demographic, medical and reproductive history data collected at the baseline, women who were followed for subsequent pregnancy outcome, confirmed by telephonic interviews for records. And the exclusion criteria, multiple pregnancy, chronic pre-existing disease such as diabetes, hypertension, heart disease, women who were already pregnant at this time of enrollment, but there was no reason why it was this case, and had also the fourth one had incomplete data or were lost at the follow-up. This diagram showed what I already explained. The primary outcome was for this study was a composite of APOs defined as the occurrence of one or more of the following in the subsequent pregnancy. And the data analysis used was a crucial Wallis test, chi-square test, the odds ratio, and the 95% confidence interval, restricted cubic splint analysis. 3 models were analyzed. It was divided into 3. First was an unadjusted model, model 1, model 2, which I will explain in the future slides. This is done to remove any confound factor that can affect the relationship between the pregnancy loss and the adverse pregnancy outcome. Let's analyze the first table. We can see here the variables that were used were age, pre-pregnancy BMI, education level, ethnicity, menstrual regularities, age of first pregnancy loss, number of pregnancy and number of pregnancy losses, and type of pregnancy losses. It was divided into 2 groups, like I said, the non-APO and the APO. And the p-value was on the loss column. If we take age, let's consider the loss column first. We got a p-value of 0.244. A p-value of 0.244 means it was not statistically significant. But in this group, we can see most women were between 25 and 29 years old. So what do we interpret is a maternal age distribution was similar between both the APO and the non-APO. If we consider the second subcategory, which is the BMI, the p-value of 0.486, which is not statistically significant, then we can see here also the most patient had a BMI between 18.5 to 22.9. The third subcategory, which is the educational level, with a p-value of 0.011, which is significant. So we will focus on this. We can see here in the APO group, 71% of the APO group had high school or less education as compared to those with a higher education, which has a 63.4% in non-APO. So what do we conclude here? It's the lowest education level is associated with high APO risk. The other groups which was statistically significant was the age of the first pregnancy with a p-value of 0.002. Here we can see that the APO group mean age was 26.6 versus 25.9% in the non-APO group. So what does this mean? It's the women with older age at the first pregnancy were more likely to be exposed to adverse pregnancy outcome. Next significant one was age at first pregnancy. We can see that the significant value, the p-value of 0.007. Here we can see that 66.9% of the APO group had pregnancy more than 26 years old versus 58.3% in the non-APO. So if we interpret this data, we see that it confirms a trend that women more than 26 years old or at first pregnancy are at a higher risk of APO. And if we see the number of pregnancy losses with a p-value of less than 0.001, we can see here that 45.5% of APO group had 2 prior pregnancy losses versus 39.1% in no APO, and 24.3% had more than 3 losses. So this interprets that there was a strong correlation. That means more previous losses is equal to greater likelihood of having an adverse pregnancy outcome. Also, we can see in the last one, the type of pregnancy losses. It was a p-value of 0.031. It was subdivided into primary and secondary. What is primary? It's the first pregnancy loss before any live birth. And the secondary was a loss after at least 1 live birth. We can see here that the APO group had more primary losses, 81% versus 75.1%. So what does this table represent? It represents the significant predictors of APO in this cohort was first, lower educational level, lower age at the first pregnancy, higher number of previous pregnancy losses, and type of pregnancy losses. And this one, which was not significant, was age, BMI, menstrual irregularities, and total pregnancies. The second diagram is a pie chart. This pie chart summarizes 460 total APO events that was observed. Here we can see the different subcategories and the percentage of this. And we can see the majority of them, like about 35% had pregnancy loss, and amniotic fluid problem like 11%, preterm 10%, fetal distress 10%, placental problem 3%. And in this pie chart, what we can see that the most frequent APO is pregnancy loss, suggests a strong recurrent risk among women with prior loss. But also this pie chart reveals that pregnancy loss does not merely predict over miscarriage. It can also lead to placental dysfunction, metabolic disorders, and vascular complications. The third table. This table, if we analyze it well, it is divided into the exposure, the unadjusted odds ratio, the model 1 and model 2. So what is model 1? Model 1 was if there was an adjustment was made for age, BMI, education, and ethnicity. Model 2, there was adjustment was made for age, BMI, education, ethnicity, menstrual irregularity, number of pregnancy, and type of pregnancy losses. So what is odds ratio. Odds ratio is a measure of association between an exposure, and in this case, exposure was pregnancy loss, and the outcome. In this case, it is adverse pregnancy loss. We need to remember only three values. A odd ratio is equal to 1, odd ratio greater than 1, odd ratio less than 1. If the odd ratio is equal to 1, this means there is no difference between the groups. An odd ratio greater than 1 means the exposure increases the odds of the outcome. An odd ratio of less than 1, the exposure reduces the risk, the odds of the outcome, which is a protective mechanism in this. If we see in the first unadjusted odd ratio, we patient with 2 prior losses, we got an odd ratio of 1.62. What does this mean? This means women with 2 losses had 1.62 times higher odds of an adverse outcome. And we can see here also with a greater than 3 number of pregnancy loss, the odd ratio was 1.78. This means that there is 1.78 higher chances to develop an adverse pregnancy outcome. What is trend test? It shows here response relationship. As the number of losses increases, APO risk also increases. If we see in the model 1 and model 2, if we take the model 2, we have number of pregnancy losses of 2, and the other remains statistically the same. So what in model 1 and model 2, the researchers adjusted for factors like age, BMI, and education, and the association remains significant, proving the relationship is independent. This curve is a restricted cubic splinter regression curve. It shows a nonlinear relationship between a continuous variable. Here in the continuous variable is the age at the first pregnancy and the odd ratio of the outcome, which is here as the outcome is the adverse pregnancy outcome. It allows researchers to visualize how the risk changes gradually across different ages rather than grouping women into fixed categories. There is 2 axes, the x-axis and the y-axis. The x-axis shows the age of the first pregnancy, and the y-axis shows the odds ratio of adverse pregnancy loss. We got a horizontal dashed line at odd ratio of 1. This is a reference line, represent no increased effect. The vertical dashed line at the age of 26. It is an age at which risk is normalized to a ratio of 1 at this point. We get the red curve and the shaded area. The red curve is a fitted odd ratio trend line showing how risk changes with age. And the shaded area is a 95% confidence interval. As we can see in the diagram here, if we take the vertical line here as a 26 years old, on the left side, we can see that on the left side of the women, which is less than 26 years old, we can see the graph here. The odd ratio is less than 0.1. No, sorry, the odd ratio is less than 1. And like I said here, when the odd ratio is less than 1, it is a protective mechanism. And you can see here, with the curve remain close and below odds ratio 1, suggesting that the younger first pregnancy has slightly lower risk of developing adverse outcome. And on the right side of the 26 years, we can see that it increased above the odds ratio of 1. The curve begins, and what does this mean? This means at this age of pregnancy, increases odd ratio of adverse pregnancy outcome. The limitation of the study, it was a single center design limited to northwestern China. Possible recall bias, self-reported pregnancy history, and the third one is unmeasured confounders such as lifestyle, infection, thrombophilia were not analyzed. The study found a significant association between previous pregnancy loss and increased risk of adverse pregnancy outcome in the subsequent pregnancy. Women with 7 previous losses had approximately 2 times higher risk of APO. Women with 3 or more losses had 3 times higher odds of adverse pregnancy outcome. The association remains significant of the adjusting confounding factors like age and education. Old maternal age at the first pregnancy also independently increased APO risk. The findings were consistent with prior international and Chinese studies showing a positive correlation between recurrent miscarriage and later pregnancy complications like preterm gestational hypertension and GDM PET. Recurrent pregnancy losses is not only a reproductive problem, but a predictor of maternal and fetal morbidity. Targeted pre-conception counseling and early prenatal monitoring are essential for women with history of miscarriage. The take-home message here is pre-conception counseling must be done. Establishing targeted preventive strategies and prenatal care for women with prior losses may improve maternal and neonatal outcome. We must investigate patients who had recurrent losses. Ongoing and recurrent monitoring during subsequent pregnancy, being for high alert for APO. Also, we must create an environment that supports younger women to start their families while pursuing their career. Thank you very much.
Thank you, Dr. Buba. Any comments or questions from the House before we go to the online? Nothing here. Online, any comments? If not one, just one. That's really, we talk about pre-pregnancy counseling. If all that the pre-pregnancy counseling is just going to package to say, well, you got a high risk of adverse outcome, and the bits are like, here, that's what one. So what are you going to do about it? What do you need to do about it? That's what obviously the people want to know. Is there anything that you can do? I have risk of adverse pregnancy outcome. I know the article was not addressing that. It's just warning us that the patient has had 2 or 3 previous pregnancies. They are at the high risk of adverse pregnancy outcome, diabetes, hypertension, whatever you know in terms of that. Yes, we can possibly screen them for diabetes screening, and obviously maybe, I don't know, whether we should be starting them on low dose aspirin or not in front of that. But it's just a question that I think the people want to know, is there anything that we do differently in this index pregnancy, given that after the high pregnancy, after the previous pregnancy losses. I think that's where I think further research would probably focus on that. But this that was the article tell us that. I think the idea that we should be telling people to have their pregnancy a little bit earlier, I'm not sure that that's achievable. I think obviously Chinese people are really career oriented, and they tend to begin to start their pregnancy later. And we are seeing the same trend now that people are pursuing their careers, and we are having quite a bit of increased numbers of people that are having their first pregnancies after the age 30 or so, or later 20s. So whether we would be able to tell them to have their pregnancy earlier while pursuing their careers, I think it's doubtful to me into that. But yeah, the article just tells us what we probably would have suspected, and it's just proven that yes, it does get associated with adverse things that come in the pregnancy. Any other comments online over here?
Yeah, Dr. Mason and Dr. Bupa.
Yes,
Yeah,
Prof.
thanks for the presentation and your attempt to describe that graph, that statistical graph that we're hearing. I'm personally hearing about it for the first time. I guess as we advance in our sector, the statisticians are also finding various ways to define their findings and stuff like that. Because there have been other graphs that have been used. It's the first time I hear about this. What did they say? Some cubic what restricted
Yeah.
cubic. Yeah, which apparently just basically defines relationships between nonlinear parameters, which I can't remember what else we've used before. But it's good that you applied yourself to try and understand what that means. And so did Jauri. We appreciate that, and I think it's the essence of learning. Yeah, I don't have much to say really, as Dr. Maise is saying. The article really highlights we've often looked at recurrent miscarriage and the risk of the next miscarriage, 2 or 3, and now here they are making associations with adverse outcomes, even if the pregnancy was to proceed. Again, alerting us that there could be some other underlying factors that are beyond the first or early trimesters. And therefore the pregnancy remains at risk, regardless of whether it advanced to viability. Yeah, thanks for that, for both of you and the consultants who supervised. Before I get off the mic, a reminder about the end of the year party, which is about 3 weeks now away. There is an account on the slide where you can deposit and send your proof of payment to any of the admins, Sia or Grace, or else to the organizers, which is your registrar reps, Masondo and Zita, assisted by Nkuna and Sitole. And we did invite anyone who wants to join them on the program. Oh, sorry, and Kanana also is also in the team. Yeah, thanks. Before I get off, the consultants, please, we are at the end of November. Please be assessing your registrars. The due date is next week, Wednesday, on the 26th. All registrars should have had their 6 monthly assessments. They are needed upstairs on the 28th. So our cutoff in the department is 26th, so that we can consolidate the assessments, and they must reach postgrad office by the 28th. So registrars is also the onus is also on you to make sure that you've had your evaluation wherever you are posted. Otherwise, you will not be evaluated, and as you know, that the postgrad office is tightening measures more and more, and we cannot escape anymore to make your 6 monthly assessments and evaluations. So it's a call to both registrars and consultants to do that. Those of you that are outside of your time and have not written your appeal letter, yesterday was your cutoff. I have to make a consolidated appeal upstairs. Again, if you know anyone who has not sent their letter, they may not get the grace period come next year, January, and we will not be able to defend. This measure goes to what is called CAB, which is CAAB. It's a unit or whatever that is higher than our school. So whatever the school or we as a department report to the school, to CAB, and CAB cannot handle matters that have not been presented to them. If you have not written your letter, you need to do so by 10 o'clock today, because I need to send that comprehensive covering letter. Similarly, with the registrars that are delayed, you are still within the program, but you are delayed with your MED milestones. We need to have a conversation in the next few weeks, ASAP, before the things are demanded of us. I will arrange, I know there's a few of the 2024 registrars that are struggling with their breaks and issues like that. We need to have a conversation soon. I'll alert you as to either a Wednesday or Friday that we remain and see exactly where the problem is. We've been dealing with you guys one by one, but maybe we need to come together with everybody else who's delayed in their MED. Yeah, thanks, Dr. Maisa.
Thank you. Good day. Bye.